This conference will now be recorded.
Okay, good afternoon, everybody. Can you hear me?
Yes, sir. Audible. Yes, sir.
Is the sound less? You want to increase the sound? Now is it all right? Hello?
Yes, sir. All right.
Okay. Huh? Is the sound less or what?
Sir, normal sounds.
Excuse me?
Sir, clear voice. Your voice is clear, sir.
Okay, okay. So let's start today. So we are talking about the anal canal today, and this is one of the very important parts of the human anatomy. The reason I say that is because if you look at the attendance at the surgery OPD, you'll find that more than 40% of patients, almost 40% of patients, come to us with various kinds of anal problems. And these are the benign problems that we have every day. Like, for example, the fissure in ano, the fistula in ano, the hemorrhoids, which build up the maximum number of patients of the OPD attendance in a surgical unit. So that's why anal canal is not a very uncommon problem. It's one of the very common presenting diseases in the surgical OPD. So let's start with the surgical anatomy of this, and we'll start with the development of the anal canal. If you look at the derivation of the hindgut, the hindgut, you'll find develops from the cloaca and ectodermal. It's got both endodermal and ectodermal origin. So the terminal part of the hindgut is the cloaca with the allantois connected to it. So this is basically the allantois connected out here. You'll find it out here, and this is the cloaca. And here you have got the cloacal membrane, right? Now a urorectal septum starts developing, and then it starts bifurcating the whole of the cloaca into anorectal canal, the posterior, and the urogenital sinus anterior. So that is basically the work of the urorectal septum, which is trying to separate it into the two parts, right? And here it's almost complete. And it also divides the membrane of the cloacal membrane, two parts. One is the anal membrane, the other is the urogenital membrane, right? So if you look here, the divides into urogenital anal membrane, and the mesenchyme also is around the anal membrane is the anal pit. Out here is the ectodermal and the lower part of the anal canal. So this is basically lower part of the anal canal. You've got the ectodermal component to it, right? Now, if you look at this development seen in a basically sagittal view, you'll find that this is the peritoneal cavity, and this is the primitive urogenital sinus out here, and this is the part developing as the terminal most part of the hindgut. And this is basically the ectodermal component of the anal membrane out here, and this is the ectodermal component which make and unite together at the region of the dentate line. This is what it appears like in a diagrammatic view in adult, right? So you've got the endodermal and the ectodermal anal canal. Now we'll talk about that in the further slides. Now we have to make a differentiation between the two important parts of the anal canal, and the surgical anal canal and the anatomical anal canal, because subsequent to this slide, our total discussion would be on the surgical anal canal and not on the anatomical anal canal, right? Total. So when you talk about the anal canal, we talk about the surgical anal canal. So basically, what is the difference between the two? We have to understand that. Now, if you look at the surgical anal canal, it's the part of the terminmost part of the intestine, which is lying below the anorectal ring or the anorectal flexure up to the anal verge. So that particular segment is the surgical anal canal. Okay. Now, purectalis muscle is forming that sling or the anorectal sling, which is demarcating, and it is anteriorly kinking the anorectal junction. So whatever part of the anal canal is lying below this perirectal area or the sling up to the anal verge is basically the total surgical anal canal. In contrast to that, the anatomical anal canal is only part of the canal which is below the dentate line. So this is a shorter part, right? Now, surgical anal canal is completely extraperitoneal, about 4 centimeters. The range is about 3 to 5 centimeters in length, 2/3 or half above the pectinate line, and 1/3 to half below the pectinate line. Now, what are we trying to say? Look at this figure. It shows you a more complete picture out here. And if you look at this, this is the dentate line we're talking about, and this is the area of the surgical canal, right? So if you look at this, this is the area. See this levator ani, the purectalis part levator ani, fusing with the deep part of the external anal sphincter. Now, this is the part up to see out here, surgical anal canal. And if you look at the anatomical anal canal, it is only from the dentate line downwards. So this is basically roughly equal or 1/3, 2/3. That varies from person to person. So this whole thing is the surgical anal canal, and this partly is basically the anatomical anal canal. Now, between the anatomical anal canal and the anal verge, this is the verge, you've got the white line of Hilton or the intersphincter gland. We'll talk about that in one of the future slides, right? So just to make the anatomy clear, you've got the surgical anal canal, you've got the anatomical anal canal. So there's surgical anal canal, the anatomical anal canal, and the anatomical anal canal is further subdivided into two by the white line of Hilton or the intersphincter gland, right? So we've got three major parts to the anal canal. Now, what are the gross anatomy of the surgical anal canal? So as I said earlier, we'll only be referring to the surgical anal canal from now on. Now, there are certain definitions of part of the anal canal which you'll be coming across in your lectures or in your readings, and these are some terms which may slightly be confusing. In the sense, what is the anal margin, what is the anal verge, because they could be often, they are not distinctive and they can be used instead of the other one. So they can be interchanged, but that doesn't mean that they are the same thing. They are meaning two different anatomical landmarks. So what is the anal verge? Is the junction of the keratinized squamous epithelium, the anal canal, without the appendages. See, this is without the appendages with the hair-bearing keratinized perianal skin. So on one hand, you've got the normal skin with the hair and the other appendages. On the other hand, you've got the keratinized squamous epithelium without the hair and the appendages. Both of them are keratinized, right? So anal verge is the junction between the non-hair bearing and the hair bearing, non-appendages bearing and appendages bearing, right? Both of them are keratinized. What about the anal margin? Anal margin is you add about 2 to 5 centimeters to the anal verge onto the perineum. So they basically talking about an area which is lying on the skin. Lying on the skin. This was an area which was lying between the skin and the anal keratinized non-hair bearing area. So that is the junction between the two, and this is basically a part of the skin. So this is basically lying wholly on the skin. So on either part of this junction would be hair bearing, right? What is the pectinate line? Pectinate line, we all know, also known as the dentate line, is the site of transition of the ectodermal and the endodermal part, right? So post-allantoic gut and the proctodium, which is the ectodermal part. So that is the junctional area. We know that. What is the white line of Hilton? We will be referring to that. And the white line of Hilton basically denotes the intersphincteric septum or the lower end of the internal anal sphincter, circuited by the medially curving fibers of the longitudinal muscle. Now, what do we mean? Just tell you in the future slide. What are we basically meaning? So now we know these four things: anal verge, anal margin, pectinate line, white line of Hilton. You may be wondering, why do we need to have a distinction between anal verge and anal margin? Obviously, it's a logical question. Why the need? Because this is basically a very fine distinction. Does it really have any logic in trying to differentiate between the two? It is logical. Why? Because the malignancies of the anal verge and the malignancy of the anal margin are distinctive malignancies, right? They don't interchange. Malignancy arising from the part of the anal canal behind the anal verge and that part is lying beyond the anal verge are distinctive. That means they're different. And that's why the need to differentiate this anal part into the two, that the anal verge and the anal margin. Now let's have another figure. Now this will show you much better. So basically what we're looking at now is a rectum, a coronal section of the rectum, right? This would be the same thing. All the same thing. This is a more diagrammatic representation, like less diagrammatic representation. So what do we have? We have the rectum. Then we got the transitional zone, and here you see the walls. These are the pectinate line. Below that, you got what is known as pecten, and here see the anal verge. And here, let's go down here. Anal verge, and below this, what do you have? The anal margin. That's the perianal skin. So that is basically what we're talking about. This is different. They're not the same thing. They're not synonymous. They're different. And here you got the sphincter muscle. You got the internal sphincter, you got the external sphincter, and in between you got the longitudinal sphincter. Here you got the intersphincteric groove, what we are just now talking about, right? This is the area of the intersphincteric groove. This is the internal sphincter, the curving fibers of the external sphincter, and here basically the longitudinal muscle curves. It curves. Can you see this faint fibers out here? We'll show that in one of the future slides. So these are the fibers which curve and make the intermuscular or intersphincteric septum, right? A septum lying between the internal and the external. So I hope this part of the diagram is pretty clear. So now this anal canal, we are not referring to anal to anatomical surgical. We are now only talking about the surgical canal. That's why what do we say? Levitani and the internal and the external. So this is making what? The sphincter complex. Making what? The recto-anal junction or the anorectal is hinging the whole of the lower part of the rectum and the anal oblique. We'll just talk about that what the anorectal is all about. So from here down, we have this whole thing. We have this whole thing up to the anal verge as the anal canal. Is that clear? So the transitional zone, the curving fibers or the anal walls, and below that the dentate line up to the part up to the anal verge. Right? Now, what is the lining? We just talked about this. So is the lining different from here to here? Or are they the same mucosal lining? No, it is different. So let's see what the lining is all about. The anal verge or the anal verge is the junction of the keratinized squamous epithelium or the anal canal without the appendages with hair bearing. So what do we mean? What do we basically mean? We're basically meaning what? We're talking about these two areas. So here you have hair bearing and appendages in the skin. Here you will not have any of that. Both of them would be keratinized. Remember, both keratinized. But here, no appendages. Here, appendages, including the hair. That's part one. The anoderm. What is the anoderm? This part is the anoderm. See, this part is the anoderm. What is known as the pectin? This whole thing is the anoderm. Now, what does that include? The anoderm is further subdivided into part proximal and distal to the white line of Hilton or the intersphinctic line. What do we mean? We basically mean this line drawn out here would be below and beyond. That means proximal and distal. So this would be different, this would be different. How are they different? Let's see how they're different. The difference is basically that the part proximal to the white line, which means what? Between the dentate line and the white line. That's proximal to the white line. So it looks thick, pearly white, parchment-like skin. It is absolutely parchment. And it is very, very adherent. You can't move it over the deeper layer. That means there's hardly any some mucosa there. It is sensitive like a skin. How do we know that? Because the fissure always lies in this white sensitive skin. And a fissure is very, very painful. So we know it is basically a sensitive skin and non-keratinized. See, we were just talking about the keratinization, non-keratinization. We said that this part is non-keratinized, keratinized without appendages and keratinized without appendages. Now we are saying it is non-keratinized. So what is non-keratinized? If you draw a white line out here, above it is non-keratinized. So non-keratinized, keratinized without appendages, and keratinized with appendages. Clear? Very, very simple. Very, very simple. So if you have a white line out here, so here non-keratinized, keratinized without appendages, and keratinized with appendages. Is that clear? Very simple to remember. If you remember this, you'll remember the whole of the anatomy of the anal canal. So part distal to the white line, we just said keratinized, does not have any skin appendages, and non-hairy stratified squamous epithelium. So here basically you got one type of epithelium, here a different type of epithelium, here a third type of epithelium, right? And above this, the rectum has got a fourth type of epithelium. Okay, and the most distal 5 to 10 millimeters beyond the verge. That basically means what? Between the verge and that's the anal margin. So here what do we have? Keratinized with appendages. Okay, so I'm not repeating that again. Okay, now what is the pectinate line? Let's look at this figure. This is basically the pectinate line. So this is basically a demarcation formed by the anal walls in the adult. So in adults, how do you know this is the pectinate line? We'll find walls out here. We'll find walls and you'll find crypts out here. And these are what? These are transverse folds of mucosa. That means instead of the longitudinal folds, you also find some transverse folds lying below, right? At the inferior most ends of the anal columns. And they are what? Above this is the pit, and into the pits, the anal glands open. So these are anal sinuses or pits above this. These are longitudinal column. So here somewhere you would be having the openings of the anal glands. Now, it is very, very peculiar and very, very characteristic that if you're doing inspection in clinical practice, like for example, a proctoscopy, right? You will not be able to see a pectinate line very clearly. Remember that. Is not seen on inspection in clinical practice. That means proctoscopy. But if the same patient is under anesthesia, the anal canal descends down and the pectinate line can be seen on a slight fraction of the anal canal skin. It's very, very clearly demarcated. You can see it demarcated very, very clearly. So what is the pectinate line doing? We just not talked about that. It is basically junction, endodermal, ectodermal. So above you'll have the portal circulation. That means here portal circulation. See, port to the venous system. Below you have the systemic. So here it goes to the systemic circulation. Autonomic nerve supply above and sensory below. Lymphatic drainage to the internal iliac and inferior mesenteric group. I'll just show you above, and to the inguinal group of lymph nodes below. And that is why we say that if you have a malignancy of the anal verge or the anal margin, the most important group to be involved, the lymph node to be examined, is the inguinal. While if you have a malignancy above the pectinate line, this is only involved as a later progression of the disease. So primarily here, the spread from here would be toward the internal iliac. The spread from here would be below the pectinate would be towards the inguinal group of lymph nodes, right? Now let's see the lining. We just now talked about the lining. What is the lining? So here in the rectum, you've got what? Columnar epithelium. We all know that. But what about this transitional zone? This is the transitional zone. So transitional zone has a cuboidal epithelium. See, cuboidal stratified epithelium. And that makes a difference in the type of malignancy we're talking about, right? We can talk about squamous from squamous epithelium. We talk about columnar from columnar epithelium, while which is cuboidal can either be a squamous or it could be a columnar. So that is why it's important to remember that here you have columnar. Here you start having a stratified cuboidal. Okay, stratified cuboidal. So up to this part, it will still be red colored, just like in the rectum. But when it comes toward the pit, it becomes plum colored. And that is why if you do an examination of a hemorrhoid, it is always plum colored, not only because of the viscosity of the vein, but also because of the plexus lying underneath, even under normal circumstances. Why? Because the internal rectal venous plexus, even without hemorrhoid, is lying out here. Can you see this? So this part, or the terminal part of the transitional zone, is always plum colored. So at the anal crypts is plum colored. So red up to here, then plum color. Now what about the pectinate line? We just not talked about that. That is basically a area which is white. It is white. Why white? It is parchment. Talk about this particular mucosa out here. Now the mucosa in this particular transitional zone, it is thrown into longitudinal folds. Can you see these folds? Here are the folds. They denote the folds. So longitudinal folds of the mucosa. Now three among them would be very, very prominent. And these three prominent folds are found at the termination points of the branches of the superior rectal artery. And that is why we find them where a left lateral one and then two right lateral, that is posterior and anterior, that is 3, 7 and 11. That means you'll find one here and one here if you're looking at a coronal section, right? So basically what we talk about is that these are the prominent folds, and these prominent folds are also known as the anal cushions. They're also known as the anal cushions. Why cushions? Because they are prominent than the other longitudinal folds. They are more prominent. That's why they're known as the anal cushions. Now, what do these anal cushions contain? They contain branches and tributaries of the superior rectal and the artery and the vein, right? And they become more prominent when there is viscosity of the vein, meaning thereby that an internal hemorrhoid, a patient has a disease of internal hemorrhoid, they would be much more prominent. So even under normal circumstances, you have to remember that they are prominent than the other longitudinal folds. It's not that if you find just a slight amount of prominence, you say this is an internal hemorrhoid. No, that's wrong. That's wrong. They would be prominent in the other longitudinal folds as it is. But in a patient with internal hemorrhoid, they become all the more prominent, right? And among them would be other longitudinal folds, which we have just now referred to. They are known as secondary vertical folds, right? And they form together what? The anal columns of Morgagni. So these are the anal columns of Morgagni. Can you see these? So you have the cushions and you got the anal columns of Morgagni, right? So just remember, two things are lying in the transitional zone in the mucosa. There would be three cushions and there would be further vertical folds known as anal columns of Morgagni. And they number about 6 to 10 vertical folds in the upper part of the anal canal. Now, at the bottom of these, what lies out here? Sinuses of crypts, right? And below the crypts, you got the anal walls, which demarcate the pectinate line. And into these pits out here, what opens up? 1 to 6 anal glands, and there are other pits where nothing opens. It's not that every pit has to have an opening of an anal gland, right? There would be certain where there is no opening of an anal gland, right? Now, what is we talk about anal glands? What are these anal glands? These are basically glands which are rudimentary in the humans. They have got a major role to play in the animal population. But in the humans, they are probably rudimentary. They only secrete some of the mucus to lubricate the anal region. That is perhaps the only function of the anal gland. That basically means there is something which, when it gets infected, is very troublesome. If it's not there, would not be troublesome for you. But then that is how the human being has evolved. So here the glands are branched and they're lined by against stratified columnar epithelium, right? So that is the reason why certain anal malignancies can be columnar malignancy. Now you know it. Anal malignancy by and large are what? Squamous cell malignancy, right? But if they are columnar malignancy, then you believe that probably they are arising from the anal glands which have got a stratified columnar epithelium. You remember that? Good. Now, these glands, they have got cystic dilatations and may extend through internal sphincter even up to the external sphincter. Now, the problem is, where are they lying? In which plane? Now, this is the mucosa. This is the mucosa. Internal sphincter, longitudinal, and here you got the external sphincter. This is the submucosa. This figure is not exactly right. Why? Because this particular area does not have any submucosa. Okay. We just not talked about that, the pectinate. Now, they got a varied position. They could be found in the upper submucosa. They could be found inside the external sphincter. They could be found in the intersphincteric plane, which is denoted by the longitudinal muscle, or they could be found even in the external sphincter. So normally, where do they lie? They lie in the intersphincteric plane, and that is the plane between the longitudinal muscle and the external sphincter. So this is the plane. See, it's extending up to the same. Here it is lying in the submucosa. Okay, so the position is predominantly intersphincteric, but it could have varied position lying in the submucosa, the internal sphincteric, the intersphincteric, and the external sphincter. And we just now said ducts open in the anal crypts, and 1 to 6 glands are opening out there. But the problem with this gland is that if it gets infected, then it gives rise to the perirectal, perianal abscesses, and further on to a generation of a fistula. And that is a cryptoglandular theory of the formation of a fistula. We'll refer to that when we talk about the fistula. Okay. Now, if we have an overview of the internal lining, I just not told you: colorectal, simple columnar; transitional, simple columnar, and then stratified. We just talked about that. The plum colored, the inoderm, stratified squamous non-keratinized, and below the white line, it is basically stratified squamous keratinized epithelium without appendages or hair. This is a very good method of remembering the 4 types of the transition of the internal lining from columnar up to a keratinized non-appendageal bearing, and then onto the skin, which is keratinized appendageal bearing. Right? Let's look at this figure. This very good figure. It shows you the pectinate line out here. You can see the crypts out here. These are crypts. These are the anal, the walls out here, and you got the sinus and the crypts out here. See, this is base. See this white line, the indentation. That's the white line. And where is it ending? This is the end of the internal sphincter. What is this? External sphincter. And what is out here? This is the longitudinal muscle. We just refer to that in one of the further slides, right? When we talk about the muscle. So the conjoined longitudinal muscle, you got the internal sphincter, the external sphincter, the white line, and together, this together from here to here is basically the pectin, the inoderm. This is slightly wrong out here because inoderm has got various meanings, but we would only refer to inoderm as the part lying below the pectinate line and in between the white line. Okay, and this is the intermuscular groove of white line of Hilton. Is that clear? Now, this is a part of the anal canal again. I just show you these figures so that makes anatomy much more clear to you. See, this is the longitudinal muscle, the internal sphincter, the external sphincter, which joins the levator ani to form the complex. This is a sphincter complex. And see the longitudinal muscle giving out a number of fibrous interstices, which are basically crossing the internal sphincter and the external sphincter. We just talk about that. The pectinate line, and we already referred to that. This is just to make it more clear. And this is basically what? This is basically the issue-rectal fossa. And this is how the nerve comes. With this figure in mind, you'll be able to understand much more clearly. This is how the nerve comes, and which now we're talking about the inferior rectal nerve. I'll just tell you. Okay, that's another picture. This is another picture to show you the same thing. the anal glands. See, non-keratinized squamous, white line. Below the white line, what? Keratinizing squamous epithelium without appendages. I was just telling you that. And this is basically what? This is basically the anal sinuses, the anal columns of Morgagni, and this is the dentate line. So now I hope this part is much more clear to you. And see again reference to what? The anal canal, the anatomic anal canal, extending up to what? The pectinate line, and surgical anal canal, extending up to what? The levata ani and the fusion levata ani and the deep part of the external sphincter, external anal sphincter, right? So this probably makes it much more clear. And just remember this figure, keep that in mind, and it will be much more crystal clear to you. And just remember this figure, it tells you how the nerve crosses the ischiorrectal space and comes onto the anal canal. Right now, what are the muscles of the surgical anal canal? Let's talk about the muscles. They've got a very important role, and we talk about 4 muscles. Number 1, the pelvic sling, which is part of the levata ani, the puborectalis part, and the puboanalis part, and the coccygeal muscle posteriorly. And we'll talk about the 3 sphincters: the external sphincter, the longitudinal sphincter, and the internal sphincter. Right? Now, let's see the puborectalis. This is how it hinges. See the pubic bone, and this is the anterior-most part of the levata ani, forming the 2 parts. One which is hinging the anorectal, and the second part which is basically giving out the analis part, or the part which is nearer to the anal canal, right? So here basically we're talking about the puborectalis muscle sling, the internal anal sphincter. See, this is the external, the anal, and the internal sphincter, and this is the rectum is how hinging it, and that forms the anorectal angle for you. That forms the anorectal angle. And this anorectal angle normally measures between 108 to 127. So this angle, when you measure this angle, it's always more than 90 degrees, always more than 90 degrees. And when there is a contraction and release for defecation, the alteration of the angle would be only by 15 to 20 degrees only. So the anorectal angle becomes much more obtuse during defecation. That means they will straighten up. When it straightens up, what happens? It makes it much more obtuse. Okay, you know, obtuse basically means more than 90. So this is basically how it looks like. Coccyx posteriorly, pubis anteriorly, and that is how it's doing. So when they're trying to relax, this would basically be easing itself out. Okay, now what is the external anal sphincter? Measures about 8 to 10 centimeter. What length are we talking about? Anterior posterior. And when the defecation occurs, the sphincter muscle relaxes and retracts. It comprises 3 parts. Now, are these distinct parts? No, they have been made distinct in order to explain it. It's one single muscle with 3 different parts to it. They are not separate from each other. Remember that. They are together. But they can be differentiated with 3 parts to make the explanation easier. The deeper part, the superficial, and the subcutaneous. Now, this part is probably very, very important. Why? Because the deeper part, the fiber of the deeper parts are intermingling with a number of other fibers. What are those fibers? Number 1, we just now said the puborectalis muscle and the analis muscle. We know that. Why? Because the sling is forming out here. The sling is forming out here. So it is making intermingling fibers out here. What else is lying out here? The longitudinal muscle. So intermingling with the longitudinal muscle, right? Now in the anterior part, when this muscle goes anteriorly, where is it going? Anteriorly, basically, it is going towards what? The penile area or the perineum in the female. Now, there it is intermingling with what? Some fibers cross over the midline to blend with the superficial transverse perineal muscle of the opposite side. So now we know the sphincter complex is made up of 4 important muscles, right? And what are those 4 muscles? One, the deep part of this external anal sphincter, the part of the levata ani, which part? Puborectalis and analis part, the longitudinal muscle, and the superficial transverse perineal muscle. So 4 parts to the anal sphincter complex, anorectal sphincter complex. Is that clear? And this part is perhaps very important. Why? Because it is in major part responsible for the continence. Not the only part. Remember this. Not the only part. It is part which is partly responsible. And posteriorly, this deep part would be inserting way into the anococcygeal ligament. That clear? The superficial part, which is lying in between the subcutaneous and the deeper part, is again inserting the perineal body anteriorly, just like here, and the anococcygeal ligament posteriorly. Right? Some fibers may cross over to the other side. It does not have a major role to play as such. The subcutaneous part of the external anal sphincter, which is basically this part, it lies just underneath the skin. So when you're trying to palpate the muscle underneath the skin, you're palpating the subcutaneous part of the external anal sphincter. and it's surrounding what? It is surrounding the lowermost part in the area of the anal verge. See, this is the anal verge and this is the subcutaneous part. So it is surrounding what? The lowermost part of the anal canal, which is basically the anal verge. What is the nerve supply? The somatic innervation from the inferior anal nerve, a branch of pudendal nerve. As a result, the muscle is under voluntary control. This is a sensory branch. So that means this muscle is under voluntary control. Inferior rectal arteries, branch of what? The posterior branch of the internal ilia, right? They run along with the nerves, and the terminal branch of the internal pudendal arteries, which are branches of the posterior branch of the internal ilia, right? So, and small supply from the medial sacral artery, and that confirms to what we just now said, the ectodermal part and the endodermal part that's lying beneath the part which is basically lying under the dentate, because that is the part which is being supplied, that's the part which is supplying the external anal sphincter. The action of the muscle is slightly peculiar. In what? It is in a state of tonic contraction. Remember, it is not relaxed at all times. Just like the internal anal sphincter, this is also in tonic contraction, but does not have any antagonistic muscle, and it keeps the anal canal and orifice shut. It keeps it shut. That's why it only relaxes when you got the willpower to do so. When you want to defecate, you defecate. How do you do that? You relax your external anal sphincter. Until you decide to do so, you keep it in a tight contraction, right? So it keeps the anal canal orifice shut. It can be put into a condition of greater contraction under the influence of the will. You want to defecate, the circumstances are such that you can't go to defecate, so you try to close it much more harder. So it is a position to put it into greater contraction until you have the will to defecate, and take it a fixed point at the coccyx. So anococcygeal raphe is the fixed point. So anteriorly, it is going to fix the central perineum for you, so that the bulbospongiosus muscle may act from this fixed point. So it fixes the perineum, the anterior perineum. So it has got, number one, the effect of keeping a tonic contraction. It is under the effect of the willpower to keep it so. And number two, it can be, it helps in fixing the anterior part, which is the perineum, so that the muscle lying further anteriorly, they got a fixed point to act from this particular side. The internal anal sphincter, this is an extension of the circular muscle of the rectum, right? Now, external anal sphincter does not have any connection with the rectal muscle as such, because the rectal muscle got the circular and they got the longitudinal, right? Now, the inner circular part is continuing into the anal canal as the internal sphincter, right? Ring of smooth muscle. That's why those who have seen hemorrhoidectomy done, or those who have had a chance of doing it, they would find that as soon as you cut through the skin, you'll find those circumferential white looking fibers running like cords all around, like rings. That is basically the internalmost part of the internal sphincter, right? It surrounds 2.5 to 4 centimeters the anal canal, right? That basically means what? That basically means it is surrounding 2.5 to 4 centimeters of the anal canal. Okay, now 5 millimeter thick, that is the thickness. So it is covering 2.5 to 4 centimeters, 5 millimeter thick, and the lower border, if this is the opening, is lying about 6 millimeters from the margin of the lumen, right? From the orifice of the lumen, it is 6 millimeters of lumen, and it's always in a state of contraction. Remember that. It is the tonic contractor of the anal canal, always keeping it in tonic contraction. It has got three kinds of supplies: sympathetic from L4-5, parasympathetic S2-4, and the non-adrenergic, non-cholinergic fiber. Now, what are they doing? Apart from the sympathetic, which keeps in perpetual contraction, the rest are relaxants of the sphincter. That means the moment you have parasympathetic stimulation, or the moment you have a nitric oxide release from the NALC fiber, they release what? How do they act? They act by release of relaxant nitric oxide. So as soon as these two fibers are stimulated, the sphincter will relax. As it is, it's always in a tonic contraction, and see, responsible for almost 75% of the resting tone of the anal canal, right? So 75% of the resting tone is mediated by the internal anal sphincter. Relaxation, I just now said, by stimulation of parasympathetic, stimulation of NANC fiber. One more important thing which relaxes the sphincter is the local rectoanal inhibitory pathway, or the RAIR pathway. This is set up through the NANC fibers. And how is it set up? As soon as the lower rectal sensory fibers are stimulated with the arrival of feces, two fibers are stimulated. Number one, the lower rectal, at the same time, the pelvic floor fibers are stimulated, leading to what? Leading to a reflex, which is going to act at the anal sphincteric motor fibers, giving rise to either a inhibition or a relaxation of the anal sphincters, right? So these reflexes set up, and that reflex is between the local rectal and pelvic and the anal fiber. So that is basically an inhibitory pathway. It can also act as a stimulatory pathway depending upon the ease for defecation. Is that clear? Now, what is the role in incontinence as far as IAS is concerned? Contributes, I just now said, about 75% resting tone. We all said that. It is a very important for bowel continence, especially for liquids and gases. That is primarily mediated by the IAS. So when the rectum fills beyond a certain capacity, the rectal walls are distended, triggering the defecation cycle. Now, this begins with the rectal anal inhibitory cycle where the IAS relaxes. So, as soon as a bulk arrives in the rectum, the IAS says, I have to relax. Why? Because I would like to send the allowed defecation to go on. Right? Now, it is thought to allow small amount of rectal content. Now, the IAS doesn't relax fully. It just sends a sample of fecal content to the anus. See, this is the anal canal where specialized mucosa samples what? Whether the fecal mass is actually gas, liquid or solid. So that is basically a sampling mechanism by partial relaxation of the IAS as soon as bulk arrives in the rectum. Is that clear? Bulk arriving in the rectum, the body has to sample, the anus has to sample what it's getting. It samples whether it is gas or whether it's liquid or solid. If it is gas, you pass a amount of gas. That is basically what is the passage of gas through your anal canal. Now, how does that occur? The feces don't pass. It's only passage of a large or small amount of gas. Why does it occur? That is basically because your anal mucosa has sampled it as purely gas and it allows it to go. But if it has got a solid content or liquid content, it would see whether the moment is opportune for defecation, only then it's going to release, right? And that is why if we have a problem with the IAS, it presents as a degree of fecal incontinence, especially incontinence to liquids or mucous rectal discharge. That means your IAS not working properly. The sample which was sent had some amount of liquid in it. The anus relaxed under the pretext that's probably sending out gas, but it also passed some amount of liquid, right? So that is the continence, the incontinence with the IAS problem. Now coming perhaps one of the most interesting muscles, and that's the longitudinal layer or the conjoined longitudinal layer. See, this is basically the longitudinal layer we're talking about. The internal sphincter, external sphincter, the longitudinal muscle. Now what is this longitudinal layer? It is nothing but a continuation of the what? Tinea coli. I just now told you the wall of the rectum has got circular muscle that continued as the internal sphincter. The outer tinea coli or the vertical continued as the longitudinal muscle, right? It has got two parts to it. It has got fibromuscular and it's got connective tissues, not purely muscular. Remember that the longitudinal muscle is both a fibromuscular and it has got connective tissue, right? And where is it lying? It is basically the intersphincteric space between what? See, this is the intersphincter. Can you see this figure? See the arrow, intersphincteric space between what? The longitudinal muscle and the external. Right, so that is the intersphincteric place, not the intersphincteric space out here. So it is a space between the longitudinal and the external anal sphincter, not between the external and the internal. Is that clear? So intersphincteric space is the space between the longitudinal anal muscle and the external anal sphincter. Right? How is it formed? It is a continuation of the vertical rectal muscle. Agreed. In addition to that, what else do you have? You have the fusing fibers of what? Levator ani. They are fusing not only with the deep part of the external anal sphincter, they are also fusing with the longitudinal muscle. So fusion of striated muscle from the puboanalis, the innermost part of the puborectalis, and the smooth muscle from the longitudinal muscle of the rectum, the tinea coli. Right? So we got three parts to it. The longitudinal muscle would be having fibers incorporated from the levator ani, and will have fibers incorporated from the tinea coli or the longitudinal muscle from the rectum. Okay. Now it extends as a muscle bundle or incomplete sheets of muscle. So it is not one continuous. It has got so varied picture. It could be a continuous sheath of muscle. It could be interrupted sheath of muscle, or it could be interspersed sheath with a fibrous tissue. Right? And it would end where? It ends at the lower border of the, see, it's ending out here. See, ending out here. So lower border of the internal sphincter. And from here, it becomes completely fibroelastic. That means loses all muscular component. It has got fibro and elastic components. And what do these components do? They split into septae. From here, it starts sending out septae all along, laterally, downwards, medially, and from medially upwards. So these are septae which split running between the bundles of subcutaneous external sphincter, terminate laterally in the penile skin. So this is what? This is the subcutaneous sphincter, right? Subcutaneous, superficial, deep. So fibers or septae would start running out here. So they're passing through the superficial part of the external sphincter, and they go and stick to the skin, giving rise to the typical puckering of the anal canal. Typical puckering of the anal canal. And it has got one problem with it. And that is the applied importance is that because it goes and attaches to the skin, it creates closed spaces there. And if you have infection in any one of these closed spaces, as in perianal abscess, because it cannot expand much, it gives rise to severe pain. And that's why a perianal abscess is severely painful, an intersphincteric abscess may be less painful, a submucous abscess is less painful. A perianal abscess, purely perianal abscess, is a very, very painful condition. The reason is simple, because the pus is collected in a closed space formed by what? By the septae which are running between the longitudinal and to the skin. And that is why it cannot expand, and that's why it gives rise to severe pain out here, right? Now, the area bounded by these septae is generally referred to, in this particular area, the marginal and the perianal. So perianal also has got two parts to it. See, this is the marginal, this is the lumen, and 4A is the marginal, and beyond that is the perianal, true perianal. So perianal can be divided into two. One, the marginal, just lying in contact with the margin, and this is the true perianal. Now, what else does it do? So these were the fibers we were talking about. See, the longitudinal muscle sending fibers out here. The lateralmost fiber out here is known as the transverse fibrous septum of issue-rectal fossa. And those of you who have a chance to drain issue-rectal abscess, you'll always find that when you give the incision, you will encounter a fibrous layer out there. And that fibrous layer is nothing but the transverse fibrous septum of the issue-rectal fossa. See this fiber running out here? External sphincter, internal sphincter. Okay, now, so these are the fibers from lateral to medial. Now, what does it do? From here, see, this is the lowermost part of the internal sphincter. It curves below the internal sphincter and goes up. So it is making a sort of a curve and then ascending up. When it makes a curve, it is demarcating what? The intersphincteric area. That means the area between the external and the internal sphincter. That is basically, and see the white line? Can you see the white line out here? So this is basically the intersphincteric line. That's the intersphincteric line, right? So the anal intermuscular septum and the intersphincteric groove. So this basically is demarcating that. So this too is the groove, and this is basically the part which makes the anal intermuscular septum. And then it ascends up and sends fibers to the mucosa. See, this is the mucosa, this is the pectin, and it fixes the mucosa to the underlying layers. There is no submucosa out here. And that is why this part of the anal canal has got a layer which cannot be made to move over the deeper layers. It anchors it with the help of what? It anchors it with the help of a muscle out here, the musculus submucous ani. That means sends fibers out here, which may be partly muscular, maybe only fibrous, and it hinges the mucosa out here. So it is very, very simple to remember that up to the lower end, it is either fibroelastic or muscular. Below this, the longitudinal phase. So this is the longitudinal layer. Is purely fibroelastic. From lateral to medial, it starts sending out fibers into the issue-rectal space known as the transverse fibrous septum, into the skin, which gives rise to the corrugator ani picture, and then forms the intermuscular septum, the groove, the intermuscular groove. And it is very, very important to remember that this is all very important part of the anatomy. Remember this. Why? Because in the approaches to the parts of the anal canal, in the diseases, this part forms a very, very important part. So remember this, basically the groove. This groove is very important, the intersphincteric groove. Why? Because this is the groove through which you can easily enter into the area which would be between the internal and the external. This is the area from which you enter. You don't enter from here. You don't enter from here. You're going to enter from here. So an approach into the intersphincteric area between the longitudinal and external oblique into this area is always through the groove. And the reason why you have this adhesion is because there is a tight adherence of these fibrous septa to the mucosa. Is that clear? Right. Now, basically, with the passage of age, what happens? With the passage of age, these fibers tend to break down. Your collagen tissue tends to break down with age. 60 years, 70 years, you find your skin to be absolutely loose. Why? Collagen is gone, the fibrous tissue is gone. So similarly out here, it fragments, the fibrous tissue fragments. And then the support suffers, and then this part of the mucosa becomes loose. It becomes loose, giving rise to the typical formation of grade 3 and grade 4 hemorrhoids, which are much more common in the old age group. Right? Now, the conjoined longitudinal cord is innervated by what? The autonomic fibers. Right? The same origin as which is supplying the internal sphincter. So autonomic, somatic. Is that clear? Autonomic, somatic. So sensory out here, these two are autonomic. Now, what is the function of the longitudinal muscle? It basically, when it contracts, it pulls by the fibrous septic. And that leads to what? The anal lumen widens. It's going to pull everything apart. See, the fibers acting out here would be contracting here, here would be contracting here. So it is widening the anal canal. What else? The fibers which are contracting here would pull the anal canal up. So it is shortening the anal canal, right? And when it's shortening, it would be flattening and everting your anal cushion. So basically what you're doing is, when it's attached out here, it would be flattening. See, it's flattening out here. So anal cushions are flattened, everted, anal canal is shortened, anal lumen is widened. But these are not major functions of longitudinal muscle. They are there, but probably they may not have any important function to play. And the applied importance, just now told you, is basically the applied importance to approach into the intersphincteric area. See, this is I try to make a diagram out here. The three parts of the external anal sphincter: the subcutaneous, the superficial, and the deep part. This is the internal anal sphincter. This is a part of the longitudinal muscle. Now, where are the anal glands? Most commonly, where they found? In the intersphincteric plane. That is between the longitudinal muscle and the external sphincter. Now, I told you, what is this line? See, the line is basically the intersphincteric line. See this line approaching from here, the white line. So the approach for the intersphincteric plane is through this area, and it is important where? In two important areas. It may be important even for otherwise, but in two important areas. Number one, when you want to ligate a fistulous tract out here. See, this is a fistula, this is a fistula, and you do an intersphincteric ligation of fistulous tract. Probably many of you wouldn't be knowing what we're talking about. This is basically intersphincteric ligation. See, you're ligating out here. So what do? We do a curettage and then we ligate. I'll talk about that when we talk about the fistula. Another very important application of this plane is where? When you're doing an intersphincteric excision of the rectal carcinoma of the lower third part, which is now one of the accepted methods. In lower third of the rectal carcinoma, the treatment is APR. Okay, abdominal resection. That basically means what? The whole of your anal canal goes. So you're basically excising what? You're excising this whole thing. You throw it out. So now how does the rectum open? You have to do a colostomy. Now that patient is subjected to a lifelong colostomy. But suppose if the patient has got a rectal malignancy just limited to this particular area, maybe I can do something. I don't want to do an APR. Why can't I cut from here to the intersphincteric plane? Why can't I do that? So it forms a new approach to the management of rectal carcinoma. The intersphincteric excision. Intersphincteric excision. What am I excising? See, I'm excising this. What am I leaving behind? The whole of the external sphincter. What am I leaving behind? The sling. So would this patient continent? Yes, he'll be continent. So at least I am saving him the colostomy. So that is the new approach to the lower third of the rectal carcinoma, which until lately was subjected to the final treatment of APR. Is that clear? So this is the applied importance of the intersphincteric plane. So this is how it looks like from external. See the tenia coli forming the longitudinal muscle, inside circular muscle. So longitudinal circle, and see this is the levator ani. That is how it encloses. The whole thing is basically like a clamp. It's like a clamp. And here you got the fibrous septum and the corrugator cutis ani muscle. What is that? That is basically the fibers of the longitudinal muscle. They form the corrugator cutis. Right? We have already talked about that. I won't be wasting time on that. So what about fecal continence and anal continence? Just a few words about the physiology of the anal canal. Now the two terms are different. Fecal incontinence and anal continence are probably different. Fecal incontinence, basically, we talk about some form of encopresis. I'll talk about what encopresis is. Encopresis is a form of fecal incontinence. It's a lack of control over your defecation, right? So you have an involuntary loss of what? Liquid and mucus and solid, right? But when this includes gases also, it is referred to anal incontinence. So when you talk about anal incontinence, you talk about basically both the flatus and of course along with that the liquid and the solid elements, right? In fecal incontinence, we only talk about the solid and liquid elements along with mucus, but no flatus. Now, there are two factors most commonly involved in anal incontinence. One is the coronary contraction or motility, and number two, the sphincteric injury or the sphincter defect, which we are concerned with. We already talking about sphincter injury, where in a patient or in a multiparous female. When are we talking about it? Fistula, we operate on fistula. When else are we talking about? We are doing a fissure nano, and your over exuberance, instead of 3-finger dilatation, you do a 6-finger dilatation. What happens? Everything broken. So we are always worried about the sphincter of the anal region. A lot of clinical conditions where that becomes very important, right? So this anal incontinence has been classified in 3 different categories. Number 1, fecal seepage. What is fecal seepage? You have gone and you have defecated, and subsequently what is happening? You consciously feel that a fecal matter is leaking during or after exercise, any violent expulsive event of the abdomen. Passive incontinence, when the patient is not aware, he's not aware. In the evening, he removes undergarments, he finds there's fecal soiling over it. He never knew about it. That's passive incontinence. And then urge incontinence. And the patient unable, he has to go to defecate, he's trying to hold it. I just told you, the moment not opportune, I like to hold it. I can't hold it. That is basically urge incontinence. Just like in urge incontinence in the urinary system. It's simply out here. Now, whenever you have a sphincter injury or sphincter defect, it basically falls into the fecal seepage category. That is the most common type of incontinence that we have once you have injured your muscles or you've had your muscles injured by somebody. Okay, and that basically means some kind of a doctor. Okay, so when you talk about the continence and functional anal canal components, I'll just give you a brief summary of that. I'm not going into the details. The IAS, what does it do? The internal anal sphincter permanently contracted. We talked about that, the tonic contraction. It provides the resting anal tone, reinforced by what? Reinforced by the external anal sphincter, which acts like a clamp, anal clamp. And what else is helping it? The anal mucosal folds. What else is helping it? The anal cushion. So together, they make it a watertight chamber. A watertight chamber, so that you don't soil a cloth. So the internal sphincter, the external sphincter, which acts like a clamp, and from inside, you have what? The longitudinal fold, that is the column Morgagni, and the endovascular cushions. Together, all 4 make it a watertight junction. What about the external anal sphincter? I just all told you it acts like a clamp under your voluntary control. You want to defecate, you don't want to defecate, that's under your control. And basically, when you have some kind of a EAS injury, you would be having what? Urge-related or diarrhea-associated fecal incontinence. Pure rectalis is basically a part of the levator ani. We all talked about that. And that is basically leading to a bending closure by maintaining the anorectal angle. And it has to act together with the EAS. So EAS and pure rectalis, they are probably acting together. Why? Because both of them are making the anorectal angle. Together they make the anorectal angle, the deep part of the EAS. And that is why they are both helping in the control, and also because they got voluntary control, right? Now, the anal cushion, so endovascular cushion, I just now told you, that is making a watertight chamber. They make a watertight chamber. And during defecation, what happens? When you want to defecate, you have a opportune moment. Now what's going to happen? The internal sphincter relaxes. As soon as it relaxes, it drains the vein from the cushions. The venous blood from the cushion drains out. So what happens to the cushion? They collapse. What happens to the column Morgagni? They collapse. So when they collapse, the lumen becomes patent. So during defecation, the internal sphincter relaxes and the blood drains away from the cushions, allowing a smooth passage of the stool through the anal canal. Right? And damage to these cushions, they provide a poor anal seal. So that seal which was there, if you have a damage to the cushions or if a damage to the IES, this seal will not be working, and you have impaired anorectal sampling reflex, we just not talked about. You have injury to the pudendal nerve, neuropathy, you have diminished rectal sensation. So you never feel the rectum to be full. So what's going to happen? It keeps on accumulating inside the rectum, gives rise to fecal impaction, megarectum, and fecal overflow or encopresis. Obstetrical trauma, which is perhaps one of the most common, even commoner than the fistula in anal operation, where you tend to damage the muscle. This is the most common cause of anal sphincter disruption. It may involve both. Why? Because you're doing episiotomy, you did a very over exuberant episiotomy, you damage both the external and the internal anal sphincter and the pudendal nerves, single organ combination. You damage it when the female was in the childbearing age group 20-30. But what is very typical is that it presents with fecal incontinence at that age group, but more commonly in the 50 years of age. And when you take a history, this patient will give you a history that yes, I had episiotomy at the age of 30. Why this happens, we still don't know. But that is very typical, that if the damage has not been total, then at the age of 20-30, when the episiotomy was done, at the age of 50, they would be manifesting with this kind of problem. Now, what about the nerve supply of the anorectal region? I told you about the pectinate line and below the pectinate line, above autonomic nervous system. Where? See, this is basically the superior hypogastric plexus. We all know that. Getting fibers from lumbar and getting fibers from S234. See the fibers arriving from there? The superior hypogastric. And then device also known as the presacral nerve. Remember, when you take the superior hypogastric plexus, the other name is the presacral nerve. Never forget that. Right. So it divides into two, giving rise to the two inferior hypogastric plexus on the right and on the left. So this is a hypogastric plexus. Where is it getting fibers from? See, S234. A very good pictorial representation. Fibers from S234. So that is the inferior hypogastric plexus, where it is getting fiber from the sympathetic, right? Sympathetic, lumbar, and getting from the fibers from the sacral, which is the parasympathetic outflow. So parasympathetic and sympathetic, right? Hypogastric plexus nerve and the parasympathetic, and they unite where? In the inferior hypogastric plexus. So in the superior hypogastric plexus or the presacral nerve or the hypogastric nerve, it is purely a sympathetic. And here basically, when you talk about the inferior hypogastric plexus, which is two on either side, you got a mixing up of the sympathetic and the parasympathetic fibers, right? So they unite in the inferior hypogastric plexus, and then they are distributed onto the organ. See the organ, the bladder and the rectum. That's where they're distributed. Okay, this is the levator ani. You can see it out here. Now below the pectinate line, it is a somatic innervation. From where? See, this is the pudendal nerve. S234, the pudendal nerve. I showed you from the issue fossa, and from here it then divides into two: the inferior rectal nerve and the perineal nerve. Right? So the inferior rectal nerve and perineal nerve, both of them are both sensory and motor to the muscles and mucosa below the dentate line. So see, the pudendal nerve dividing the inferior rectal nerve and the perineal nerve, supplying what? Supplying the anal canal, both what? Sensory fibers and both motor fibers. And the root value is from the same S234, which was supplying the parasympathetic fibers. Here it is supplying the sensory and motor fibers. Is that clear? So the main outflow, or the nerve inflow to the anal canal, is from S234, and to a certain extent the hypogastric from L4 and L5. Is that clear? So sympathetic from L4, L5, and S234 parasympathetic and sensory and motor. Vascular supply above the pectinate line, the superior rectal artery, which is a terminal branch of the inferior mesenteric. We all know that inferior mesenteric artery is superior rectal artery. And it may also get some fibers from the internal ilia, which is the posterior division. See, this is the anterior posterior division, the middle rectal, and you got the inferior rectal. We're supplying the inferior. So that is the total supply of the anal canal above superior rectal artery and below the middle and the inferior rectal artery. The drainage is again from the superior rectal artery into the portal circulation. Into the portal circulation, a very small fragment where we go into the middle rectal artery into the systemic circulation. Where? Through the internal iliac vein. There's the internal iliac vein going into the common iliac, and also from the external, which is now going where, or the inferior rectal going where, again into the common iliac. So this is the systemic and this is the portal circulation. Is that clear? So that makes a plexus out here, the internal hemorrhoidal plexus, and this makes a plexus out here, the external hemorrhoidal plexus. Now where are these plexus lying? I just not talked about that. The internal hemorrhoidal plexus lying where? In the cushions. We just talk about the cushions. What do the cushions contain? They contain the superior rectal artery, a twig, and superior rectal vein, a part of superior rectal vein. So that together makes the internal hemorrhoidal plexus. Now, where is the external hemorrhoidal plexus lying? This is lying in the perianal area, that's the subcutaneous area and the perianal area, right? What we depicted as 4A in one of the figures. That is where it's lying. Yeah, see, This is where, can you see these veins out here? Can you see these veins? These are the veins which are the external hemorrhoidal plexus. See, external rectal venous plexus. And this is basically the internal. This is a very, very clear picture. The pectinate line. And what is lying above? Columns of Morgagni. What is this? The cushion. Very easy to remember. So the cushion and the column of Morgagni, you've got these veins out here, chiefly in the cushions, the three cushions. Why? Because that is where the terminal branch of spherical artery is ending. So that is where the cushion gets the maximum supply of the artery and the maximum outflow vein. And where the external hemorrhoidal plexus? In the subcutaneous part, what is known as the perianal or the 4A part. Okay. So that is right. And what about the lymphatics? Lymphatics, again, very clear. The part which is the superior part is draining where? Into the sigmoid, from the sigmoid into the inferior mesenteric lymph node around the inferior mesenteric vein and the artery. So basically, the part above the pectinate line will be draining where? Will be draining into the sigmoid and into the inferior mesenteric. And what about the part below? The below would be draining into the inguinal and to a certain extent into the presacral group of lymph nodes. Is that clear? So that is the lymphatic drainage, and that helps in deciding which lymph nodes would primarily be involved in which part of the malignancy, involving which part of the anal canal. Above the pectinate line, we're looking for the lymph nodes inside the pelvis and the abdomen. Below, we're looking at the inguinal lymph node. And that is why we have to understand what this is all about. The spaces, this part of the anatomy, like to clear. The spaces around the rectum and the anal canal is very, very important. And when you talk about the spaces, you just have to remember two things. One, the anococcygeal raphe. See the coccyx? See the anal canal. And number two, you have to remember the levate ani. Is that clear? When you remember these two, you would be in a better position to understand the spaces around the anal canal. This is very clear. The perianal, we just talked about that, is very clear. The perianal, basically the marginal, and the perianal, which is lying more laterally, right? But these two spaces divided by the anococcygeal raphe divides into two spaces. One, the superficial postanal space and the deep postanal space. So the anococcygeal raphe divides the area behind the anal canal into two spaces, the posterior and the superficial postanal space, the anococcygeal ligament. Above that is basically the levate ani. And above the levate ani lies what? The sacrum. So in between the sacrum and the levate ani, superficial levate ani, you have what is known as the presacral space. So three spaces, or rather five spaces: the marginal, the perianal, further laterally the superficial postanal, the deep postanal, and the presacral space. Would that be clear? So five spaces which are there behind the anal canal and on the lateral side of anal canal. So if this is the anal canal, these, the posterior, the anterior, these spaces would be from the lateral to this side lateral and behind. So they're basically extending 3 to 9 and behind, that basically means 6 o'clock. This would be the spaces lying out here. What lies anteriorly? Anteriorly, what would be lying is basically the bladder and the prostate in a male or the uterus in a female. So you got all the spaces which are lying in between the rectum and either the prostate and the urethra in the male or between the vagina in the female. So these spaces we'll skip because these are spaces when you talk about the urinary tract and the genital system, we talk about that there. But one more space that we need to remember is the submucous space. The submucous space is between the mucosa and the submucous. See, can you see these fibers out here? What is this muscle? The internal sphincter. So what we're talking about is the cushion area. See the pectinate line. Above that is the cushion area. So we're talking about a space which is lying in between the mucosa and the submucosa and the internal sphincter. So that is the submucous space. So submucous abscess, the marginal abscess, the perianal abscess, then we're talking about basically the issue-rectal abscess further laterally. We're talking about a deep postanal abscess, and we're talking about the levate ani or the pelvic abscess. Is that clear? So these are basically the spaces in and around the anal canal. Now, I've tried to make this a much more easier picture. Why? Because we have to talk about circumferentially communicating spaces. We in a number of conditions, we talk about the horseshoe abscess. So we can't understand the abscess here. How does it spread to one side and the opposite side? Started at 6 o'clock. Why should it spread to 3 and 9? Why and how? Now, if you remember that, I just now showed you the most important intercoccygeal, right? Lymphatics. Now, this is basically the perianal space starting from here, and this is out the presacral space, right? The marginal and the perianal, the isurectal, further depiction, and the intersphincteric, right? I forgot to talk about the intersphincteric here. The intersphincteric abscess. These are the sphincteric abscess that is basically an abscess out here. This is the intersphincteric abscess. Okay. Now, further depicted out here. So you got the intersphincteric, you got the marginal, the perianal, the isurectal, and the abscess, which is pelvic abscess. Now, do they communicate on either side posteriorly? Yes. Perianal can communicate to the superficial postanal space. See, there's a postanal space. Superficial, it communicates. Isurectal abscess communicates. Intersphincteric, yes, it communicates to the intramuscular space on either side. Isurectal, can it communicate? Yes, it communicates to the deep postanal. What lies out here? The deep postanal. That means going to communicate to this space, the deep postanal. And a supralevator, how does that communicate? That communicates through what? Through the levator ani superficial lying to it, that is the pelvic space. So that is around the rectum via the presacral space. So see, the communication occurs from one side and can go to the opposite side, or it starts in the midline and can go to both the sides, giving rise to the typical horseshoe abscesses in the perianal area. Here's another figure. This is basically a coronal view. You find the supralevator. See, this is what? The levator ani, right? The margins of the pelvis. This is basically what? The septum. We talk about the transseptum. Remember, I just now told you the lateral most offshoot from the longitudinal muscle, and that is the transverse septum. So in between, you got what? The isurectal space. Here, what do you have? The perianal space, right? So we already referred to that. Now, just coming to the investigation of a patient of a anal disease. So DRE, we all know DRE. I'm not going to go to the details of a digital examination. You start with a visual inspection of that area. Then you go and see for the puckering of the anal area. Then you look at the muscle tone of the sphincter, and then you go inside and look at the lumen and the surroundings, right? Now, a visual inspection can be done by a proctoscopy. Now, the proctoscopy is basically examination where you have a instrument of various sizes. They can extend from 10 inches to 12 inches or even longer. And basically, it has got a diameter of 1 inch. See the anoscope, proctoscope, 10 centimeter, 30 centimeter, right? So that is basically extending. So this, I'm sorry, it should be centimeters, not inches. It can be even more. Now, pediatric is basically a smaller, length is only 5.6 centimeters, and you got diameter of 18 millimeters. A sigmoidoscope, on the other hand, is 65 centimeters, this millimeter, 65 centimeters, and 1 centimeter in the diameter, right? And can visualize up to what part? Sigmoidoscope can help you to visualize up to the splenic flexion. It could both be a rigid sigmoidoscope, it could be a flexible. And then a colonoscope, again, size varies from 135 centimeters to 200 centimeters, right? The diameter from 9.2 to 12.2. And it can visualize even beyond the junction of the ileum and the cecum. That means you should be able to visualize the terminal ileum. That makes the anatomical inspection, right? What about the physiological tests? You have a number of tests which are basically relegated to specialized units and more or of experimental nature rather than of real clinical benefit. But they've got a lot of them. Degree of descent on straining, it demarcates the pelvic floor and pudendal nerve for you. The functional anal length, the internal anal sphincter activity by the resting tone, the squeeze increment, the external anal sphincter is seen by examination under endoscopic ultrasound. You see the structural integrity of sphincters. You can also do an EMG for functional integrity, evacuation proctography. They are done in specialized units, right? But coming to one of the most important investigation, and that is a MRI, which has got a major role to play in a number of diseases, chief among them being the fistula. And for your information, whenever we're talking about the degree, the 3 o'clock, the 4 o'clock, and 6 o'clock, so on and so forth, never forget this figure. The 12 o'clock is what? The mons pubis. This is the pubic bone. That is the 12 o'clock for you. And what is lying behind? The natal gland. So that is 6 o'clock, right? So when you're looking at the patient, 12 o'clock, 6 o'clock, to your right 3 o'clock, and to the left 9 o'clock. Don't forget this clock, and that will help you always in trying to tell us about the pathology at which clock you're talking about, right? Now I'll just refer to one or two congenital conditions, then we'll finish up. The first is the anorectal malformation, also the imperforate anus, and we all know that if a patient comes to you with imperforate anus, we all have to look for the vascular group of defects. And you all know what the vascular group is: the vertebral, the anal, the cardiovascular, tracheoesophageal, esophageal, renal, and lymph defects. I'm not going to go to the details of that. But just remember, the patient comes to you with ARM, never forget to examine all these areas, right? The incidence is not very rare. 1 out of every 4,000 to 5,000 newborn. Fairly, I would say, not uncommon. Not very common, but fairly common. So slightly more common in boys, and results with what? Abnormal development of the urorectal septum that is not developed properly. Right? There's some defect in the first trimester in pregnancy, and that is when the defect starts. Right? Results in what? Incomplete separation of the cloaca into the urogenital rectoanal portions. That was supposed to divide into two, it didn't divide. Why? Because the septum did not come and touch the membrane. Right? So there is some malformation. The severity of the malformation would depend at the level at which the septum failed to separate. And the defects can be classified into anatomical descriptions and in relation to the levator ani, which has probably got a more important therapeutic implication, whether the defect is a high type or low type. The WHO classification still holds true, and that is basically for the non-syndromic anorectal malformation. That means the ARM doesn't belong to a specific syndrome. So it's just in its own entity. It's non-syndromic. We have the male defects and the female defects. We'll talk about the defects in one of the future slides. The other classifications are also there. One is the wing spread classification, the Penna classification, which stood the test of time until quite lately, and then the Krickenberg classification, which is probably one of the better classifications. Why? It's incorporating three elements to it. Number one, diagnostic. Number two, surgical procedure category, and the category documenting the functional outcome. So a Krickenberg's classification is telling you three things. One is telling you the diagnostic. Number two, it's also telling you the surgical procedure. And three, it's also telling you the post-surgery functional outcome. And that is where it scores above the other classifications. Why? Because none of the other previous scoring systems had the third thing in mind. So they hardly took constipation and soiling into account when they were devising these complications. So what is the clinical scenario? Clinical scenario is a child has come to you. The parents are very much worried that he's not passed feces. So you look for the anal opening. First thing you do. So you find a normally placed anal opening. It could be bulging, it could be non-bulging. You'll find something pouting out and a blue colored, you know, it's just a membrane. You give a slit and the mucosa comes up. Right? But it's non-bulging. You find there is an anal opening, but it's non-bulging. It's normal looking. You have the puckering there. It tells you that if the puckering is there, the external sphincter is there, the longitudinal muscle is there. But still no meconium. What's happening? Probably something inside the endodermal development. And that is basically means what? A rectal atresia. The endoderm is not developed properly. Right? Abnormally placed. You find an opening, but it's not there in the normal place. It is basically an abnormal place. Abnormal means what? Up to the scrotum or penile in the male or up to the faucet in the female. It is bulging. We know the feces come to that point. It's patent but not showing any signs of feces or showing sign of feces, but the opening is at a ectopic place. Right? The third could be that you're not seeing it at all. One, you are seeing it. Number two, you are seeing it at a abnormal place, and number three, you're not seeing it at all. If you're not seeing it at all, there could be two scenarios to it. Number one, it could be with a fistula. Number two, it could be without a fistula. Without a fistula, was the patient going to present with? Acute distal obstruction. Very easy to remember that. And in those cases, you would be suspecting what? Anorectal egenesis. The rectum has not developed, probably part of the anus is also not developed. But in those patients where there's no full-blown AIO, there's some passage of fluid of the piece from somewhere, right? You find that there is a fistulous communication. In males, what do you find? You find that the penile area is stained with meconium. In a female, you find the vaginal area is stained with meconium. That means this patient got an abnormal site of the anal opening, which has a fistulous communication. And in the female, there could be one more defect, and that is a common exit, perineal exit, Common means what? Both the urinary area, vagina, and the anus are opening into one common opening, what is known as a cloacal defect, right? That is only possible in a female, hardly ever seen in a male. So if you're looking at the number one, that is anal opening is normally placed. You can have bulging anus or you don't have any bulge. So if you don't have any bulge, there's something wrong out here. There could be a stenosis or anorectal stenosis out here, or a stenosis out here. Or you could be having a rectal atresia. This has not developed, but this has developed. So you're seeing the anal opening normal, but you're not seeing any kind of bulge, no egress of mucosa. The number two, anal opening anteriorly placed. And what does anterior placement mean? Anterior placement will be anywhere from here to here. See this scrotum, even further. It could be opening here, here, or here. In the female, here, 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 up to the foreshead. Anyway, right? Now, one, it could be a tract, subcutaneous tract tracking out here. Other could be that there is a whole displacement of the lower end anterior, right? Which is known as a true ectopic. This is not true ectopic. This is a covered anus. This is a covered anus. This is not a covered anus. This is a true ectopic anus. So, number one, you could be having a horizontal tract, which is an anoperineal fistula, or you could be having an oblique tract, which is a rectoperineal fistula. It would appear something like this. In one, it is like this. In the other, what's happened? The whole thing is displaced anteriorly. Here, the whole thing is displaced anteriorly. Right? So the males look something like this. In the female, it is a vestibular fistula. So either rectovestibular or it could be a anovestibular defect. Right? The next is you don't find any visible opening. So then you're looking for meconium stains. And the most common defect in the male is what is known as the rectobulbar or the rectourethral fistula as the bulb. That is rectobulbar urethral fistula. That means there is the bulbous area, so it has come and opened out here, and the patient passing meconium through the penile. Right? That is the most common defect in a male. In the female, the most common is basically the foreshead anus that we just saw out, the vestibular anus. Right? In the males, without a fistula, you have either rectal agenesis or anorectal agenesis. Now, when this is opening out here, it could well be opening here, or it could be opening here. So then it will be known as prostatic urethra, or it will be known as rectovesical. Right? So you could have either of the three outcomes in a fistula. Right? When you have a fistula without any visible opening. In the females, you can have either here. See, this is the vagina. Can you see the vagina? So it's opening below or it's opening high in the vagina, high vagina in the foreshead. So you can have a low rectovaginal, high rectovaginal, or you could be having this kind. See what's happening out here. One common opening, bladder, vagina, and fecal. So that is a cloacal defect for you, right? So all three opening into one. So in a female, you could have either a low rectal, a high rectal, or you can have a cloac. If there is no fistula, rectal agenesis and anorectal agenesis, right? So that is how. Now, this patient has come to you. The first thing what you're doing is you're looking for the anal opening. You can have either of the three eventuality. If the anal is not seen, then what do? In males, you're looking for the meconium stain. Females looking for the meconium stains, or look for a common orifice, just as I talked about. Also examine for the abdomen. Remember that. Abdomen, why? Because this patient could be coming to you with frequent vomitings, abdominal distension, right? Acute intestinal obstruction. So if this patient has no anal opening, if the patient has an anal opening, it's easy to diagnose. See, this patient got a low type, right? If the patient does not have an anal opening, that is where the problem arises. You have to decide whether it's a low type of defect or a high type of defect. And what does this mean? That basically means that if the defect is falling short of the pelvic diaphragm, it has to be treated differently. If it is coming beyond the pelvic diaphragm, it has to be treated differently. Pelvic diaphragm basically is what? The levator ani. Why? Because the levator ani sling along the external sphincters are important component in maintaining what? The continence. So we just drag everything down without worrying on levator ani and worrying about the external sphincter. You have created what? You have basically created a colostomy in the perineal area. It's not under your control. So it's as good as an opening in the abdomen. Here you got an opening in the perineum without control. So that's a perineal colostomy. That doesn't do. You don't have to do that. Or rather, you can't do that. So you have to decide whether the opening is short of the levator ani or beyond the levator ani. And how do you do that? You basically do it by a number of investigations. The time-tested method which stood the test of time for a number of decades, but what you know is the Rice's invertogram or Weinstein-Rice invertogram, which is doing what? You stick a radiopaque marker to the proposed side of the anal region. If you're seeing a puckering, you stick it there and you put the child up down. That means the face down and legs up for at least 3 to 5 minutes, and then you take a scanner. What is known as the invertogram. Should it be done? No. It sends a lot of blood supply to the brain and it is known to damage the supply to the brain. And that is why normally you should not do an invertogram. So what else can you do? Basically, what you're trying to look at, you're trying to look at the gas shadow, the terminal most part of the bowel as related to the radiopaque marker, which is basically what? The site of the anal. So basically look at this side. So this is the development of the lowermost part of the hindgut, and this is the anal. There's a defect of this much. You're looking at this defect. You're at this defect. Now basically either it's more than 3.75 or less than 3.75. That's one method of looking at it. The second method of looking at it is you basically look in relation to number of other areas or other landmarks in your diagram. And then what do? You do a lateral prone exercise. So you put the patient in a prone position and just lift the lower end. That means slightly prone position in the prone position with the slight tilt head down. It's not a full tilt down, just a slight head tilt down. And what do? You relate the terminal most part of the gas shadow to what? Either Stephen's pubococcygeal line, which is basically a line extending from the upper border of symphysis pubis to the sacrococcygeal junction. Or you relate it to the eye line, which is the lower end of the ischial coma. What is the ischial coma? Ischial coma is nothing but the ossification center seen in the ischium, which basically appears like a coma. That's what basically just English coma, full stop coma. So that lower part of the coma, if you connect the two sides, then you'll be having what you see related to the lower end of the ischial coma, and you see the gas shadow in relation to a transverse line running through the lower part of the coma, right? And then what do? Then what you do is basically, see, this is what we're talking about. This is basically the ischial coma, the line running out here, and you see this is the pubic bone, upper part of the pubic bone, and that is basically, see, this is the sacrum and the coccygeal. So basically talking about a line out here and a line out here. These are two parallel lines. And what are you looking at? Now you're basically looking at the gas shadow. Gas shadow above the PC line, high anomaly. Gas shadow stops here, high anomaly. Between these two lines, intermediate anomaly. Below is basically what? A low anomaly. Very simple. So the interpretation of the invertogram is easily done by the two lines, that the pubococcygeal line, the ischial line, and where is the anal pit? Anal pit is somewhere here. Put it somewhere here. So basically you're looking at this distance and the gas bubble in relation to the pubococcygeal, which is the eye line, as related to the pit out here. Pit demarcated by what? A radio-opaque marker. That's one method of doing it. This may be subject to a number of errors basically in reading this thing and in doing it. So what is the second best method? Do ultrasound delineation of the lower end of the bowel in relation to the radiopaque marker. There's a much more better method of doing it. Or you can even do a CT MRI. The CT MRI. And in addition to this, if you're suspecting a fistula which is not clear, you're suspecting this patient maybe having a fistula, you found some trace meconium over the penile area, or you find some trace meconium in the faucet area, because you can have a fistulous communication not only with high type, you can also have it with the low type, right? So what you do is you basically just do a urine culture sensitivity, and if you find these organisms, E. coli, Klebsiella, and Pseudomonas, if they are identified in the urine, that is absolutely sure sign of a fistulous communication. Absolute sure sign. Is that clear? Because there's no reason why you have to find these organisms in the urine of a newborn. If they are there in the urine newborn, that basically means an intestinal communication somewhere. Is that clear? Now, so what is the treatment? If there's an anal opening at the normal side, the opening is at a normal side, cover defect or an oblique displacement, that's what you will decide. Is there a fistula? Yes, no. If the ARM without fistula, with acute sinus obstruction, yes, no. Is there a puckering at the anal side? These questions have to be addressed, because the puckering at the anal side basically means what? That the external sphincter is there, it is developed, and that can be taken or that can be made use of in giving some kind of a sphincter control in the child, right? So you have to address all these questions. Number one, anal opening at which side, right? Number two, is there a fistula? Number 3, is there acute cell obstruction? And number 4, is there puckering at the anal sac? Right? To summarize this, it's a complex situation, but just to make it simple, if the anal opening is normally placed, right, you can do anal VY-plasty. Stenosed area, do anal VY-plasty, or do a cruciate incision for the membrane and slit the membrane. So it is there, the membrane is there, or you got a membrane out here, the whole thing, just slit it, and you expand this stenosed side. The end. Nothing else required. And no opening is obliquely placed. See this oblique placement? Now, is it skirting the external sphincter? Yes, it is skirting external sphincter. It should have been coming from here. So this can be taken and reposited to this particular area. So remember, anal repositioning through the EAS complex. So number 1, you have to mobilize up to the levator ani, and then you have to draw it out through the external sphincter. That is very important, because that gives you total control, the child total control over his anal reflex. So that is very important, that if at all you want to do anal repositioning, it has to be repositioned through the external anal sphincter. Always reposition to the anal sphincter, whether it is a female or it is a male. This is a fortunate and it's a female. You have to mobilize everything from here, and this is the basic external sphincter. You have to deposit and bring it out. Is that clear? So remember, whenever the opening is obliquely placed and has skirted the external opening, this is also an opening out here, but here it is what? It's a covered anus. You just slit. This is not a covered anus. This is an absolutely different kind of anus. Okay, so here repositioning, here slitting, and doing a VY-plasty. Other procedures which are there for high time, there the burning question is there whether you should do a single stage or you should do a stage procedure. I think about 25-30 years back, there was no question of doing a single stage. When we were studying in way back in 70s and 80s, it was only that do a stage procedure. But times changed, and pediatric surgeon became much more proficient. So now there is a question for a high type or low type, or rather high type with or without fistula, whether it can be addressed in a single stage. And look what the pediatricians say, pediatric surgeons say, single stage procedure has less morbidity. The more mortality is less, and better continence. All 3 things are better if you're doing a single stage. In a dissection and neonatal period is easier. They're all virgin territory, absolute virgin territory. Nothing has been touched. So dissection becomes very easy. But there's no fibrous due to pouchitis. But there's a problem there. And that problem is you tend to damage things easily. The nerves are damaged very easily. So you have to be very, very careful. But you also take one other thing in mind, and that is the physical, psychological stress to the patient, the child, and surgeon are much less. So as soon as child is born, within 2-3 days, if you operate on this child as a one-stage procedure, you are dealing with everything at one go. You're giving this patient less morbidity, less mortality. You're giving this patient less psychological trauma, less psychological trauma to the parents. There's an easier dissection. Your work becomes easier, and everything is there. But you have to be very, very careful, or you create a morbidity to a certain extent if you're not careful enough. Is that clear? Right. So physical, psychological stress to the parents is much less. And what could be the single stage options? Number 1, doing a posterior sagittal anorectoplasty, or known as the PSARP procedure, where you can do abdominal-anal sacral pull-through. So this is basically abdominal-anal sacral pull-through, where you have to go in through the perineum, you go through the sacrum, and you do abdominal procedure. All 3 have to tackle together. Now, if the AAS has to be done, slightly becomes much more difficult as a single stage procedure. Right, and that is where the stage repair comes in, which has stood the test of time even now in a general surgical unit, and that is you do a colostomy at the sigmoid or transverse colon. It is always better to do scientifically. Sigmoid is better, and physically transverse is better. And delayed, do a second stage AAS or abdominal anal sacral pull-through operation. Why sigmoid is much more better scientifically? Because when you do a transverse colostomy, then in a newborn, then all the fecal contents coming out through the transverse colostomy. That means the part of the colostomy or the rest of the transverse colon, the sigmoid colon, up to the end of the bowel, that never gets any fecal content. And remember, fecal content passage is one of the most important stimulant for the growth of the colon. And if no amount of fecal content is coming into this particular part, that colon does not grow. So what happens when you go in for the second stage? What do you find? You find a microcolon. You find a microcolon which has never developed. So trying to do a pull through at that point of time becomes very, very difficult. And that is why in the sigmoid, you are giving this colon a reason to do what? Reason to grow. It should be developing along with the child. So that part of the colon would be developing along with the child. Why? Because now you have allowed the fecal content to go there. But the sigmoid colostomy is slightly more difficult than the transverse colostomy. That's why I said physically transverse colostomy is easier to do. Sigmoid scientifically should be done. Is that clear? And that is true for any kind of colostomy in the newborn child, like even for a Hirschsprung's disease. Okay, and then a second stage, AS. Laparoscopically assisted anorectal pull through is now coming into fore, and it is becoming more and more common. But remember one thing, it can never be done as a one-stage procedure. It's only in a stage repair. That means you do a colostomy, and at the second stage, do a LARP procedure, laparoscopically assisted anorectal pull through, and that is the end of the story. Congenital pouch colon has to be addressed. Often what do you happen? What happens in these patients? You find that you're searching for the colon here, 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 here. And what do you find? You land up with the colon only in the periumbilical area. And there you have to do a laparotomy because you're not able to find the colon. And what do you find? You find a congenital pouch colon, a very small pouch of colon. And then you do a colostomy out here. When you want to do a remedial procedure, it has to be 3-stage repair. Forget what it consists of, but just remember a congenital pouch colon, it has to be 3-stage repair. The last part I'll be touching upon today, just take 5 minutes. The sacrococcygeal teratoma, the incidence is about 1 into 35,000. That means 1/10 less than the ARM. ARM I told you 1 into 4,000. Here 1 into 40,000. There it is a male, here it is a female preponderance. And the tumor arises from where? The embryologically multipotent cells at the end of the cord, that is the Hensen's node of the primitive streak, which is located in the coccyx. That is the part from where it develops. And see, this is the most important. In our time, I think about 20-25 years back, we used to see a lot of sacrococcygeal teratomas. Why? Because they were diagnosed only in the postpartum. Here, now what are they diagnosed? They're diagnosed antenatally. Most of the STs are diagnosed antenatally because of widespread use of routine obstetrical ultrasonography, and that is why we hardly get a lot of patients to see. Right? The incidence of seeing these patients after birth has gone down. Pathological types are 3 types: benign 75%, malignant 12%, and benign usually in infants less than 5 months it is 75%. The rest are immature teratomas, both benign and malignant elements. It can also occur as a part of a number of syndromes. The common syndrome is the Corarino triad, because the presacral mass, anorectal malformation, and a sacral disease. Right? Now there are 4 types. There were a number of classifications, but what is now being followed is the American Academy classification. We've got 4 types. Basically depends upon the mass where it is lying. So in the first, it is primarily external. In the second, it is external but has got a significant intrapelvic. In the third, predominantly intrapelvic with some amount of abdominal and a small external. And 4, it is entirely within the pelvis and the abdomen. So it is shifting from an external to an internal. That's why that is the type of classification. 1, 2, 3, and 4. Depends upon the site. Is that clear? So how do you make a postnatal diagnosis? Child has come to you postnatally. It is easy to make a diagnosis, and you have treated as early as possible. Preferably remember 5 months of age. The moment you go beyond 5 months, then the chance of malignant transformation increases. And that is why a sacrococcygeal teratoma or SCT, if diagnosed beyond 5 months after birth, is more likely to have malignant component as compared to before 5 months. Excision of the coccyx is a must. Look for any presacral extension. That is a must. I just not told you. There are presacral extension. So we just remove the external part and you don't remove the internal part, then that creates problem. That's why coccyx has to be excised. Only then you can put a finger inside the presacral space and remove whatever is lying inside. Mortality is minimal, prognosis excellent, and the differential diagnosis is important. The anterior meningomyelocele and the post-anal dermoid are the 2 important differential diagnoses. Antenatal diagnosis now become the norm, and the mortality, anterior mortality, is basically associated in the range of 30 to 50%. And why? Because tumor morphology, hypercardiac failure, and non-immune type of hydrops fetalis. Right? And the key to optimizing survival in these fetus is basically if you can intervene before the development of a high output cardiac failure, a hydrops, and maternal mirror syndrome. So if you can diagnose this before these develop, then you're probably able to save the child. Otherwise, you'll not be able to save the child. And the pathophysiology is very simple. Here, basically, the vascular supply is coming from the middle sacral artery. We know the middle sacral artery is quite a important artery. So it is getting from the middle sacral artery, and that gets more and more of blood, and so it leads to what? The vascular steal syndrome, right? So these large vascular tumors can lead to what? High output cardiac failure. They can lead to placentomegaly, eye drops, polyhydramnios. They can lead to oligohydramnios. Both can develop. And in severe cases, a maternal mirror syndrome, which basically means what? This mirrors what? The maternal or the mother develops a symptom that mimic those of the hydropic fetus. And that's why it's known as a maternal mirror syndrome, right? And if you're doing a fetal evaluation, detailed ultrasound to confirm the diagnosis, to detect any other anatomical abnormality. That's very important. You don't jump ahead and I'll do this, and you forget about the other abnormality. And that's why a fetal MRI for additional anatomic information, a fetal echocardiogram to rule out any congenital heart disease. And then, of course, amniocentesis for fetal karyotyping has to be done. The criteria for surgical resection is not very difficult. You have to look for maternal contraindication. You have to look at the fetal gestational age of 20-30 weeks. You have to look for the favorable APVSS, which I told you about the American classification. Impending high drops there, don't do it. Normal fetal karyotype, do it. Fetal cardiac output greater than 600, that has to be adjusted for gestational age, and that can be done. Prognosis, survival rate after fetal surgery is almost 50-75%, which is not a bad survival rate. You're doing a surgery in a fetus, so that's not bad. And it's required in almost 30-41% of fetal intervention. That means basically out of these patients who come to you with SCTs, then 36-41% would require a fetal intervention. If you have a long-term comorbidity, that's usually because of obstetric uropathy, bladder bowel involvement, incontinence, because you have touched on those nerves, you're not very careful enough, and the child and the parents are not happy with the cosmetic outcomes. The last slide, and this is the post-anal dermoid situated in the sacral hollow. This is very important. Why? Because this comes in differential diagnosis. 3 important differential diagnosis when you talk about the pre-sacral in a newborn child. 1, post-anal dermoid. Number 2, SCT. Number 3, anterior sacral meningocele. And number 4 is a pre-sacral lipoma. 4 things always remember. 4 things in differential diagnosis of anteriorly lying lump in the pre-sacral space. SCT, anal dermoid, post-anal dermoid. Number 3, anterior sacral meningomycele, and a pre-sacral lipoma. Situated in the sacral hollow, we all know that, usually asymptomatic. This dermoid is asymptomatic unless it becomes very large when it protrudes through the anal opening, or it becomes inflamed, give rise to post-anal pain and signs or systemic signs of infection, becomes an abscess, or becomes a sinus when it bursts through and sinus lying between the coccyx and the anal opening, or the pus bursts through the anal opening. When you start suspecting a fistula in anal. The diagnosis can easily be done by a DRE. You can feel a lump in the sacral hollow. You can do an ultrasound, an HRS in the perineal area. You can diagnose a lump lying there, or you can do a sinogram. If you find it has burst through, put in a dye out there. You find a typical hourglass appearance of a defect or a space of lesion in the presacral area, or hourglass defect. Differential diagnosis, I told you, the SCT, anterior meningomyelocele, and also add to this a presacral lipoma. In the anterior meningomyelocele, the crime pulse is there, which is not there in any of the other 3 differential diagnoses. And the treatment is easy. You have to go for excision along with the excision of the coccyx. I think that brings us to the end of this lecture, and we're dealing with the anal canal part 2. I'll just send you over the invitation either tomorrow or day after, I think. And if you have any questions, you can switch your mic on. If not, then we can say goodbye. Any questions? Okay, then thank you for your time. We're going to the next lecture either tomorrow or day after. Thank you.
Thank you, sir.